Jack Interventions is the place. The topic is intracoronary electrocardiogram, a free and underexploited diagnostic tool in angioplasty. And I am with one of the authors of the paper. Actually, the commentary is being written by Professor Bernhard Meier from Bern University Hospital in Switzerland. I love this because this is a topic that has been around for years, and I guess we sometimes forget about it. But in this paper, or the original paper you're talking about, is Perlucci et al. Myocardial viability assessed in real time with intracoronary ECG. What role does intracoronary ECG have today?
Well, apparently a very small one, because something having been around for 30 years and not being in everybody's mind has a niche role. Now, as I point out also in my editorial, it has been around even before PCI. People had put wires into coronary arteries in animals. They even inflated a balloon to cause ischemia and see what happens behind this ischemic region where a wire was, and could be used to derive an ECG.
They simply wanted ischemia.
Yeah, sure, they wanted ischemia, of course, but it's just funny. It was around with a balloon even in the coronary arteries before balloon angioplasty was invented. That was like a year before that. Then after that, it came to my mind when I introduced coronary pacing, using the wire in the coronary artery for pacing if you needed pacing, rather than putting another wire in the right ventricle. It came to my mind that this wire could also be used to deduce an electrocardiogram from the very region at interest. And so at that time, it was in the 80s, we published a few papers on using the coronary guide wire for deriving an ECG, which will by definition give you the region of interest, because that's where you're working. It didn't seem to catch on a lot of interest, because of course you still had to hook it up to an ECG machine, which meant additional maneuvers. So there were a few articles on that, showing that ischemia can be seen more conspicuously on this wire than on the outside ECG, which is understandable. Some people even said you see it earlier, which is probably a mistake. It's just because the ST elevation is so much more conspicuous that you think you see it earlier. It's like seeing an elephant coming, you think you see it earlier than a mouse, because at the same distance you don't see the mouse, but you see the elephant, but both are at the same distance. So that was a mistake. And now this article, which is very interesting, is combining this with MR for looking whether the tissue in the region that you're going to work or not going to work is still viable. And they compare it with MR, and then also compare it to this intracoronary ECG and look at signal strength with a high-pass filter attached, and then they deduce from that whether the tissue there where you intend to work is still viable. If not, they say it's not worth putting in a stent. If it is, it is. And they compare it with the gold standard of MR, which I think is a very interesting paper. So engineering comes together with electrophysiology, with interventional cardiology.
I mean, optimally speaking, where should it be used today? Where would it help?
I think it would be nice, if, as we did for a while at our center, but even our center has given it up, if every time you're in a region you hook up this little metallic wire to an ECG machine, so you really see what's happening distal to the region where you are working, so you see what is of interest. Of course, you can also see that from leads you put on the outside of the patient, which you do in every cath lab, but some regions are not reflected by the outside leads, just because from where you put them usually. And if you use an intracoronary ECG, it's always in the right region by definition. It's always distal to where you are working.
Right.
So it could be used with every PCI. It will never be, because it has been available for 30 years. People didn't pick it up. It's not going to pick it up by this paper either. This paper is just kind of kindling the little flame, still burning a little bit again, and some people will pick that up in a very rare situation where you've passed the total occlusion. You're not quite sure is the tissue behind it still viable, and you haven't done any other tests before, so you use this technique, and you will find out with the good that they have a specificity of 90% or more, a sensitivity of 70 to 80%. With a pretty good accuracy, you can actually say, is it worth to put a stent or not? Nowadays, people, once they cross the occlusion, they put a stent anyhow, and just play it by the ear. If it wasn't worth it, it's not going to harm. If it is worth it, they're going to use it anyhow. So it's not going to change. Not going to be a change of paradigm, but pathophysiologically, it's an interesting paper.
Oh, I thought it was particularly. And I think it was the last thing that you say in the paper is the past 30 years have shown that the IC ECG is as readily forgotten as it is available.
Yeah, that's not going to change it. This is going to, as I said, stir some interest for a while, but it's not going to be a new asset to PCI like FFR has been brought in as a new asset.
Yes.
But the intracoronary ECG, which would probably give you even more information than the FFR, for some reason is not going to do it unless somebody comes up with an endpoint paper comparing using it, not using it.
Right.
But that's not going to happen. There's no industry behind it. Of course, they talk about insulated wires that may come up for even better, focusing the ECG on the territory it is. But the industry, even if somebody comes up with that, it's not going to be an industry large enough to foster research that finally will put people to do it. But just as an advice to my fellow colleagues, if you're worried about whether or not there is ischemia, the wire is there. Hook it up to his ECG machine. You don't even need those filters. Just hook it up, and you'll see an ECG from right the region where you're working, which your outside electrodes will not give you.
Well, the papers are in the Journal of, I should say, JACC Interventions, and please take a look at the pair. It's a very interesting look at intracoronary electrocardiograms. It has been around for a while, but still being researched, and obviously very interesting material. For CardioSource World News, I'm Executive Editor Rick McGuire.